tonicity, isotonic state, hypotonic state, and hypertonic state. We have all different types of saline: isotonic saline, hypotonic saline, half normal saline, quarter normal saline, 5% dextro in water, hypertonic saline. Hypertonic saline, which is 3%, 5%, it's not 0.9%. 0.9, which is they call this normal saline. Hypertonic saline, which is 3% or 5%. Hypertonic saline stands for more sodium, more concentration sodium. Normal saline is 0.9%. Okay. So we are referring to normal tonicity of the plasma, which is controlled by the serum sodium. These are the three types of tonicity: isotonic saline, hypotonic saline, and hypertonic saline. So isotonic saline, which is normal saline 0.9, hypotonic saline, which is half of normal saline, or quarter of normal saline, 5% dextro in water. Talk about hypotonic saline, which is 3% or 5%. Normal saline just 0.9%, Now serum sodium is a reflection of total body sodium divided by total body water. Serum sodium is reflection of total body sodium divided by total body water, and we get the serum sodium. Okay. So if we have a total body water and if we have a total body sodium, then we find out we know serum sodium. For example, hyponatremia, which is high sodium in blood. So it's not just caused by increased total body sodium, it can cause by decreased total body water. Makes sense because increase upper number or decrease lower number, and then increase serum sodium cause hyponatremia. For example, if somebody might, loss of volume of blood, which is loss of total body water, can also increase serum. Okay. So hyponatremia is not just caused by increased total body sodium, which is sodium intake increase, also reduce total body water. Okay. Therefore, there is an increased serum sodium concentration. So it is really a ratio of total body sodium and total body water. Yeah, of course. To determine serum sodium, so just look at the serum water. So if we want to determine serum sodium, just look at serum level. With different fluid abnormalities can lose or gain a certain tonicity of fluid. Now, talk about isotonic loss of fluid. Isotonic, which is loss sodium and loss fluid, have ratio the same like that. So that's why they did not change about concentration of sodium. So isotonic loss of fluid, Look at ratio of total body sodium and water. In this case, you are losing equal amounts of water and sodium. So I'm not sure this no, I mean this happen very often or not. How come you lost the equal amount thing? Ratio amount. I mean, it's not just it's not just one. It's not just they mean this is 1 gram of sodium, 1 gram set of fluid. No, just the ratio concentration. Hence the isotonic. So this fluid is mainly lost from the ECF, extracellular fluid. Extracellular fluid, which is the fluid outside the cell. So if the data were in the bloodstream and in interstitial space, the serum sodium concentration is normal. When losing isotonic fluid, serum sodium concentration is normal. Extracellular fluid look would look contracted. So there would be no osmotic gradient moving into or out of the extracellular fluid. Clinical conditions where there is isotonic loss of fluid, for example, like a hemorrhage which is bleeding or diarrhea. So if we have an isotonic gain, we have an equal increase in salt and water. Someone getting too much isotonic saline, which is they put too much fluid in the hospital, unnecessary, but they put too much. So normal serum sodium, so excess isotonic sodium would be in the extracellular fluid, and there would be no osmotic gradient or water movement. So if we have isotonic gain, talk about isotonic loss now, talk about isotonic gain. Isotonic gain, which is for example in hospital mà they just put too much the isotonic isotonic non-saline in and again normal serum sodium, so excess isotonic sodium would be in the extracellular fluid, which is in bloodstream. There would be no osmotic gradient for water movement. Okay. Now talk about hypotonic sodium. Hypo which is low. Low by definition it means hyponatremia. Hypoglycemia will not produce hypotonic. Low sugar not produce a hypotonic solution. Hypotonic solution. So by definition, this means this low sodium. Okay, it's not low glucose. Low glucose doesn't affect. Just low sodium, then they cause hypotonic. Most common cause of low osmolarity in plasma is hyponatremia. How? Which lose more salt than water. So therefore, serum sodium would be decreased. If losing more salt than water, kidney is probably the location of why it is happening. Main place to deal with sodium, either to get it off it or to get it back. So it's in kidney, especially when dealing with diuretics like a furosemide, okay, or HC or thiazide. Again, Most common cause of low osmolarity in plasma is hyponatremia. So we get rid of the sodium out of the bloodstream. How? Lose more salt than water. Therefore, serum sodium would be decreased. Okay, if losing more salt than water, then kidney is probably location of why it's happening. The main place to deal with sodium, either to get it off it or to get it back. So it's the kidney. Okay, deal with sodium, which you get it off it or get it back. So that's the place in kidney, huh? Especially when we're dealing with diuretics like furosemide or thiazide. So the tonicity of solution you lose in your urine is hypertonic. Tonicity of solution you lose in your urine is hypertonic. Tonicity of solution you lose. So that's how you end up with hyponatremia, with hypotonic condition. Tonicity of solution you lose in your urine is hypertonic. Hypertonic. In urine is a hyper because so a loss of sodium in the urine. So that's why it causes. So that's how you end up with hyponatremia, which is low sodium bloodstream but high sodium in the urine. That makes sense. That's how you end up with hyponatremia with the hypotonic condition. ECF concentration, which is extracellular fluid concentration, is low sodium. So with the hyponatremia, therefore the water will move into low sodium in the ECF, then which is a high sodium in the inside the cell. So high sodium inside the cell, which is the water, move into the cell. So make the cell swollen. So osmosis, remember, low to high. Okay. Example, if you gain pure water, you gain that which is extracellular fluid gain and no salt. You have a really lower your serum sodium. Okay, most common cause which is SIADH in small cell carcinoma of the lung. You gain pure water because the ADH renders the distal and the collecting tubule permeable to free water. Okay, so for example, if you get pure water and no salt, you have a really low your serum sodium. Most common cause, which is SIADH. So in small cell carcinoma of the lung, you get pure water because ADH renders the distal and the collecting tubule permeable to free water. So with the ADH present, will be reabsorbing water back into extracellular fluid compartment, diluting the serum sodium and the extracellular fluid and intracellular fluid will be expanded. The extracellular fluid is expanded due to water reabsorption, and intracellular fluid is expanded because it has a high concentration levels. These levels are not diluted. This can lead to mental status abnormalities. Therefore, the more water you drink, the lower your serum sodium levels would be. The treatment is by restricting water. So the want to restrict sodium because the sodium levels are normal. When ADH is present, you will concentrate your urine because taking free water out of urine. With absent ADH, lose free water and the urine is diluted. Therefore, for with SIADH, water stays in the body, goes into the extracellular fluid compartment, and then move into the intracellular fluid compartment via osmosis. The lowest serum sodium will be in SIADH on the board. When serum sodium is less than 120, the answer is always SIADH. Example, patient with SIADH, not a smoker, therefore not a small cell carcinoma. Therefore, look at drugs. Example, patient with the SIADH, not smoker. So not smoker, so we just rule out, not a small cell carcinoma of the lung. So then if like that, the patient with SIADH but not carcinoma of the lung, small cell carcinoma, then we think about the drugs. So what drugs cause that? It's a chloropropamide. So oral sulfurias so produce SIADH. So the drug which is a chloropropamide or sulfurilurea produce SIADH. Example, gain both water and salt, but more water than salt. More water than salt and they cause hyponatremia. These are the pectin edema states. For example, right heart failure, cirrhosis of the liver. When total body sodium is increased, it always produces pectin edema. So when total body sodium is increased, it always produces pectin edema. What compartment is the total body sodium in? Extracellular fluid. What is the biggest extracellular fluid compartment? Interstitial space. Okay. Therefore, increase in the total body sodium will lead to expansion of interstitial space of the extracellular fluid. Water will follow the sodium. Therefore, you get expanded via transudate and pectin edema. So see the patient have a pectin edema which doesn't transudate. So seen in the right heart failure and seen in the cirrhosis. So the pectin edema, like a patient have a right heart failure, and cirrhosis, have a pectin edema. So this separation between edema like that, just translate the fluid. So the reason why so get more water and salt, but more water than salt, leading to hyponatremia, hyponatremia. So the pity edema is about liver. So when total body sodium is increased, total body sodium increase, voice produce total total body sodium index the water is okay. Now example hypertonic loss of salt from the uric, hypertonic loss of salt lead to hyponatremia. SIADH, which again in a loss of water, lead to hyponatremia as well. Gaining more water than salt will lead to hyponatremia with edema. Now talk about hypertonic state. By definition, so have too much sodium, hyponatremia, or have a hypoglycemia. Talk about hypertonic, which is a high sodium. By definition, have a too much sodium or have a hypoglycemia as well. Huh? Patient with a DKA, we say diabetic ketoacidosis, has a hypertonic condition, which is more common than hypernatremia. So with hypernatremia, what does ICF look like? So because ICF inside the cells, so definitely not look like shrunken because sodium a lot in the ECF, which is in the bloodstream or interstitial space. So water will move from the inside the cell, so get out of the cell, so get into interstitial space or bloodstream. So when they get out of the cell, they make the cell shrunken. So primary aldosteronism, so which is when a loss of sodium, keep a loss of sodium, so that's make the cell shrunken. Get more water, get more salt and water. Now talk about diabetes insipidus. So diabetes insipidus, so lose the pure water. In this condition, opposite with the SIADH. So diabetes insipidus, so which is a PP a lot, for example, like that when they PP a lot out, so they lose pure water, so which is again the sodium. So versus gaining pure salt in SIADH. If you lose more water than salt in the urine, So you have an osmotic diuresis, which in mixture, if you lose more water than salt in the urine. If you lose more water than salt in the urine, you have osmotic diuresis. When there is glucose and mannitol in the urine, you lose hypertonic salt solution in urine. Baby diarrhea is a hypertonic salt solution. Adult diarrhea is isotonic. Keep in mind, baby diarrhea is different with adult diarrhea. Baby diarrhea, which is hypotonic salt solution. Adult diarrhea is isotonic. Therefore, if baby has no access to water, if baby have no access to water and have a rotavirus infection, so the serum sodium should be high because losing more water than salt leading to hyponatremia. So keep my diarrhea may be different with diarrhea in adult. Diarrhea in baby which is lose a lot of water, and if I no access to the water, then they build up and they make the high sodium. So they cause a hypersodium, hyponatremia. Okay. However, most moms give the baby water to correct the diarrhea. Therefore, the baby will come in with the normal serum sodium or even hyponatremia because denominator water is increased because the mother keep water too much. So that's why treatment is Pedialyte or Gatorade. These are hypotonic salt solution. Just give them back what they lost. What has to be in Pedialyte and what has to be in Gatorade to order to reabsorb the sodium in the GI tract? Glucose because of the cold transport. With the cold transport, the sodium has to be reabsorbed with the glucose and galactose. Example, cholera in oral replacement need glucose to reabsorb sodium because a cold transport pump located in the small intestine glutarate has a glucose and sucrose, which is converted to fructose and glucose. Or how about sweat? Sweat, which is hypotonic salt solution. If you are sweating in marathon, then you will have a hyponatremia, which is loss of water. So cause hyponatremia. Now, volume compartments. Arterial blood volume is same as stroke volume and cardiac output. When cardiac output decreases, all physiologic processes occur to restore volume. With decreased cardiac output, hypovolemia, oxygenated blood will not get to tissues and we can die. Therefore, volume is essential to our body. So volume compartment, arterial blood volume is same as stroke volume and cardiac output. Cardiac output. When cardiac output decrease, all physiologic processes occur to restore volume. With decreased cardiac output, which would stand for hypovolemia, so oxygenated blood will not get into the tissue and we can die. So that's why don't get dehydrated. Therefore, volume is essential to our bodies. We have a receptors, low and high pressure ones. Okay. We have a receptor, low and high pressure ones. The low pressure ones are on the venous side. Okay. While the high pressure ones are on the arterial side, such as the carotids and arch of aorta. They are usually innervated by central cranial nerve 9 and cranial nerve 10. The high pressure ones. When there is a decrease in arterial blood volume, which is decreased stroke volume and cardiac output, that will underfill the arch vessels and the carotid. Instead of ninth or 10th nerve response, you have a sympathetic nervous system response. Therefore, catecholamines are released. This is good because that it will constrict the venous system, which will increase blood returning to the right side of the heart. Do not want venodilation because it will pull in your legs. So catecholamines will act on the beta adrenergic receptors on the heart, which will increase the force of contraction. There will be an increase in stroke volume slide and it will increase heart rate. So plus side chronotropic effect on the heart. So increase in systolic blood pressure. So arterioles on the systemic side stimulate beta receptors in smooth muscle. So that systolic pressure is really due to the amount of blood in arterial system. So while your heart is filling with blood, who controls the amount of blood in arterial system. So while your heart is filling in diastole, your peripheral resistance arterioles that maintains your diastolic blood pressure. So when they are constricted, very little blood is going to the tissue. Bad news. Okay, good news. Keep up diastolic pressure. This is important because the coronary arteries fill in diastole. So this is all done with the catecholamines. Renin system is activated by catecholamines too. So okay. Also, so angiotensin 2 can vasoconstrictor, vasoconstrict, so the peripheral arterioles. Therefore, it helps the catecholamines. Angiotensin 2 stimulates 18 hydroxylase, which converts corticosterone into aldosterone and stimulates aldosterone release, which leads to reabsorption of salt and water to get cardiac output up. So with increased stroke volume, renal blood flow to the kidney is decreased, and the RIA, which is running aldosterone angiotensin, okay, can be stimulated by this mechanism too. Where exactly are the receptors for the juxtaglomerular apparatus? That's afferent arteriole. There are sensors which are modified as muscle cells that sense blood flow. ADH will be released from the nerve response, and pure water will increase but that does not help with increases the cardiac output. So need salt to increase cardiac output. Example, bleeding to death and there is a loss of 3 liter of fluid. How can you keep blood pressure up if normal saline is isotonic? Therefore, the saline will stay in the extracellular fluid compartment. Normal saline is plasma without the protein. Anytime you have a hypovolemic shock, give normal saline, okay, to increase the blood pressure because it stays in the extracellular fluid compartment. Cannot raise blood pressure with the half normal saline or 5% dextro. Have to use the normal saline. Don't use a hypotonic saline. Cannot raise the blood pressure with the half normal saline or 5 dextro. Have to give something that resembles plasma. Plasma without protein, which is normal saline, normal isotonic, and has the same tonicity of plasma. So then that's the reason why I give normal saline 0.9%. So polytubular capillaries pressures, you reabsorb most of the sodium in the proximal tubule. 60-80%, there is the rest absorbed in the distal and collecting tubule by aldosterone. Sodium is reabsorbed into the polytubular capillaries. Stalling force in the capillaries must be amenable to it. To stalling force, oncotic pressure pressure keep fluids in the vessel, and hydrostatic pressure is push the fluid out of the vessel. Example, when renal blood flow is decreased, with the decreased stroke volume and cardiac output, what happens to the polytubular capillary hydrostatic pressure? Decrease, right? Okay. Therefore, the polytubular occulted pressure is increased. So oncotic, which is kind of protein, albumin. So the force that keep fluids in the vessel and that is responsible for the absorption of anything into bloodstream from the kidney. This is why so PO, which is polytubular oncotic pressure, more than pH, which is PO, which is pressure oncotic, pH, which is hydrostatic pressure, hydrostatic allows absorption of salt containing fluid back into bloodstream to the kidney. Tonicity of fluid reabsorbing out of the proximal tubule is isotonic, like a given normal saline IDH is reabsorbing isotonic salt solution, but not as much as the proximal tubule. IDH contributes a pure water. IDH is a reabsorbing isotonic salt solution, but not as much as the proximal tubule. IDH contributes a pure water. Therefore, with all this reabsorption, you have an isotonic solution at the IDH effect, and the patient becomes slightly hyponatremic and hypotonic, therefore absorbs into the ECF compartment when there is a decreased cardiac output. Opposite example, increased stroke volume and increased arterial volume will lead to stretch of baroreceptors innervated by ninth and 10th nerve, and the parasympathetic response will be elicited. So elicited instead of sympathetic response. There will not be any vasoconstriction nor any increase in the force of contraction of the heart. This is fluid overload. Therefore, we need to get rid of all the volume. There is increased renal blood flow, so the RIA will not be activated. So fluid overload does not ADH be released. The polytubular hydrostatic pressure is greater than the oncolic. Even if the patient absorbs salt, it wouldn't go into the bloodstream and it would be PL. Therefore, patient is losing hypotonic salt solution would increase the arterial blood volume. Need to know what happens if there is decreased cardiac output. What happens when ANP is released from the as the atrial is released from the atria and give off the diuretic effect. And wants to get restored, and AMP is only released in volume overloaded states. Example, patient give 3% hypotonic saline. What will happen to osmolality? Increase. What will that do to serum ADH? Increase. Increase of osmolarity causes a release ADH. Example, what happens in a patient with SIADH? Decrease plasma osmolarity, high ADH levels. So example, what happens in the patient with the DI, severity diabetes insipidus? No ADH, therefore serum sodium increase and ADH is low. How to tell total body sodium in the patient? Two pictures. Patient with dry tongue receive decreased total body sodium, and the patient with the indentation of the skin is the increase of total sodium. Dehydration skin tucker is performed by pinching the skin. And when the skin goes down, this tells you the total body sodium is normal in interstitial space. Also look in mouth and at mucous membrane. If you have a dependent pit in edema, that means that there is an increase in total body sodium. SIADH gain in pure water. Total body sodium is normal, but serum sodium is low. Have to restrict water. Heart failure and dependent kidney fluid kidney reabsorption is hypotonic, so solution with a decrease particular put little more water than salt. Therefore, serum sodium is low. So numerator is increased. In the water. What is non-pharmacological for any edema stage? Treatment, which is failure liver disease. So we restrict salt and restrict water. What is the treatment for SIADH? Restrict water. What is treatment for any kidney edema state? Restrict water. Pharmacological treatment for pitting in water, which is used diuretics. Also get rid of some salt. Okay.